So, my name is Joseph Colla. I'm a professor over at the University of Illinois. I'm here to talk about spinal emergencies. So, no conflicts or disclosure to report. I'm going to cover 3 high-risk spinal emergencies using 3 clinical vignettes that were adopted from real cases. Complaining of acute on chronic back pain times 3 days. He mentions that on an MRI previously he had a bulging disc. He reports new pain radiating to his left thigh and left scrotum. On exam, he appears in pain. There are no motor sensory deficits in L1 or S1, but he has decreased sharp sensation on the left perianal region. And although he has some baseline rectal tone, his anal squeeze is reduced. So the red flags in this case are the fact that he's had a prior bulging disc, the fact that he has new radicular symptoms that are radiating to his inner thigh and his scrotum, and obviously the sensory changes in the perineum and the rectal exam. Colla is located right below the spine, which ends around L1, L2. It contains fibers from the entire L spine, L1 to L5, and the entire sacrum, S1 through S5, and some of the coccygeal nerves. It is highly involved in the regulation of the bladder and bowel. It has parasympathetic, sympathetic, and somatic nerve fibers in it. The proximal portion of the Colla is susceptible to damage because it's poorly vascularized and it does not have an epineuron. So there's variation on the definition of what Colla syndrome is, but universally they have the definition will include some bowel bladder dysfunction and some hyposthesia on the perineum, plus or minus central dysfunction, usually in the context of back pain. The usual pathogenesis is compression of this vulnerable spot, which leads to edema, which leads to like a mini compartment syndrome, which eventually goes to ischemia. Major causes implicated are disc herniations, number 1, up to 60% of cases. Recent spine surgery comes in second, and then other compressive disorders make up, and ischemic disorders make up the rest, such as tumors, hematomas, abscesses. Females are two times more likely to have Colla syndrome. There's a bimodal age and presentation, and I bring this up because we talk about this abrupt onset with the disc herniation. This usually occurs in younger patients. These patients, once identified, get decompression relatively quick, within a day or a little after on average. But this more scary cause that you get with elderly patients that have not from so much disc herniation, but kind of slowly degradation of the Colla are the ones that have delayed treatment. So it's just something to be aware of. The literature describes 3 stages of Colla syndrome. The first being Colla suspect. This is the most controversial kind. This is when people feel like they have a little bit of difficulty emptying their bladder, maybe some paresthesias or radicular symptoms to their perineum, but have no objective findings. Then there's Colla incomplete or intermediate, and these are patients that have difficulty emptying their bladder, maybe decreased rectal tone on squeeze, and decreased sensation in the perineum. And then the one that I think most people are familiar with is Colla syndrome retention. And this is where there's full retention and overflow incontinence. This is when you ask people of incontinence, this is what you're really covering. And there's a loss of rectal tone and complete loss of sensation. The point I'm trying to make is this Colla incomplete is what I want you to rethink, because this is where the saves are going to be made. If you can find it before there's complete retention, there's a much better neurologic recovery. However, also don't blow off the Colla suspect. These patients usually need to get an MRI in relatively quick fashion within days to weeks. So sometimes I'll admit these patients and do frequent neuro checks to follow up. So I want you to kind of like think about the history if we're trying to catch both CSI and CSR. First thing you want to know is ask if there are changes in back pain. We get a lot of chronic back pains in our ED, and you want to know if there's a change, especially if there's new radicular symptoms in the inner thigh or groin or perianal region. Furthermore, instead of asking incontinence, ask for difficulty pooping or peeing, which may be all that they're experiencing at this time. And instead of saying numbness, or a common question of residents asks, do you feel decreased sensation with wiping or things like that? Ask if they have any tingling or new pain shooting to that perineal region. And then ask about sexual dysfunction, because a lot of patients won't volunteer that. You want to, of course, know if they've ever had an MRI, which are bulging discs, or if they've had recent spine surgeries. It's also important to get a sense of the timing and progression of the bladder symptoms and the numbness. If this is evolving over a few hours or within the day, then that should really raise a red flag that you got to get moving. Now, I'm going to spend some time on this exam part because it's something that's kind of like, it's a big thing for me when I'm teaching my residents. It's that you want to do a complete nerve exam. I think a lot of people with back pain do the L1 to S1 pretty well, checking the function of the lower extremities. However, don't ignore the deep tendon reflexes. Colla equina technically, it's a lower motor disease, so you may get diminished reflexes on just the ankle reflexes, so don't skip that. And on the rectal exam, don't just check baseline rectal tone, because you're only going to pick up that retention. What you want to do is have the patient actually squeeze around your finger. I know that sounds ridiculous, but I usually up front tell the patient what to expect, that I'll be doing this, and I also distinguish between bearing down, which actually relaxes the sphincter, and holding in. And I specifically say it's kind of like you're trying to hold in a poop at a party, which they can relate to. And also, while you're down there, I check pinpoint sensation around the perianal regions that you're there, and that's also something I let them know ahead of time, so I'm not having this conversation while I'm performing the rectal exam. And also, check the post-void residual, because 90% of Colla equina syndrome will have an excess post-void residual, and that's really easy to do with ultrasound. So once you suspect you need an MRI, hopefully your institute will have a rapid spine protocol like ours does, which limits the time in the MRI down to about 1/3 of the time, and you won't back up the ER. If there is Colla equina suspect, you don't want to pursue the MRI in the middle of the night. Maybe admit the patient or make sure the primary care doctor knows to get an MRI relatively quick and to monitor the symptoms. And if you're going to transfer, try to get the MRI before you transfer if it's possible, because about 20% of the time only it's positive when there's suspected when people pursue this. Just remember, early intervention results in better outcomes. The next topic I'd like to talk about is spinal epidural abscess. Now, I changed this case based on a few cases we had since the last time I gave this talk, which really highlight the subtlety of this diagnosis. So here we have a 47-year-old female with a history of diabetes and hemodialysis, complaining of severe mid to low back pain. Patient was just treated in the hospital for pneumonia and got discharged just 5 days ago. This is her second visit back to the emergency department for this pain. She thought the pain was just lying around in the bed all day being treated for pneumonia, but it has gotten better. In fact, I noticed there's a walker by her, and I'm like, do you normally use a walker? No. But on the exam, besides looking uncomfortable, there is no neuro deficits. We have normal rectal tone, no motor sensory deficits, and normal deep tendon reflexes. The WBC is normal. One thing on exam that was unique was that the patient had tenderness on their spine. And just so you know, epidural abscess is one of the few non-traumatic diseases that are serious that you actually have tenderness with. So the risk factors in this are that their diabetes, the patient has diabetes, is on hemodialysis, the fact that they just recently had a bacterial infection, which is, is where it probably seeded from, and that this is not getting better, it's getting worse, and the patient's having difficulty walking, and also the tenderness that I mentioned. Spinal epidural abscess is an abscess that occurs between the dura mater and the vertebral body. Usually it's posterior, but it can be anterior as well. On average, the studies say about 75% are missed at first visit. Some estimate up to 90% missed at first visit. Well, that would be one thing if they didn't do this retrospective study that showed that more than 50% of the time there was a diagnostic clue in the first presentation to the diagnosis. You really got to be scared of this diagnosis. The incidence is currently estimated to be 5 in 10,000. This is a significant increase from 2,000. They're not exactly sure why that is, but they think it's due to more spine procedures and more use of intrathecal catheters, as well as an increase in IBDA. This is a highly litigious disease and it's high morbidity. Source of infection, as far as the most identified source of preceding infection is a cutaneous infection somewhere on the trunk, usually an abscess, sometimes in the axilla, on the belly, somewhere around there, or a severe cellulitis. The next most common identified source is a recent spinal surgery, followed by intravenous drug abuse, and then long indwelling intrathecal catheters. Now, this is not the typical, the patient that's just getting an epidural for like a delivery and OB is unlikely to get this. It's very low risk until it goes over that 24-hour, 48-hour mark. And then any other, and a variety of other infections are identified preceding. How does it cause damage? Well, there is the direct compression on the spinal cord, but most likely what is happening is that it's compressing the venous return, causing edema and compression, or directly obstructing the arterial blood flow. Furthermore, the bacteria recruit further leukocytes to this site, which release cytokines, neurotoxin, and hyperexcitatory amino acids, and it breaks down the blood-brain barrier. Most common bug isolated is Staph aureus, using methicillin sensitive, but of course we're going to cover for methicillin resistance, and gram-negative is next. Risk factors. Now, unfortunately, two most common risk factors are diabetes and hemodialysis, and that makes up about 20% of my patients, so that's not really that helpful, but it did help me in that case that we mentioned. Immunosuppressant transplant patients, intravenous drug abuse, recent spinal procedures, or recent infection, like in our case, the patient with the pneumonia. So the classic triad of back pain, fever, neurodeficits is not very reliable. In fact, less than 50% of the patient will have a fever at presentation. I'll repeat that, less than 50% of patients will have a fever at presentation, so remember that. And only about 50% will have neurodeficits. My hope is that after this talk, you'll be able to maybe pick up one of those ones that don't have a fever or don't have neurodeficits. The pain that patients experience is usually severe and radicular in nature, and sometimes you can have bowel bladder dysfunction just like Colla, depending on the location. The usual progression is back pain, radiculopathy, neurodeficits, irreversible paralysis. On the exam, you want to do the same exam I talked about with Colla syndrome, but just keep in mind, don't skip the deep tendon reflexes. Deep tendon reflexes might give you a clue. In one case, a patient had clonus, it was undocumented before, that kind of led to the diagnosis. And of course, you should do the palpate for tenderness, like I said before, and of course, you do good rectal exam, as mentioned. Diagnostic workup, you want an MRI specifically with contrast as opposed to the other two diagnoses I'm saying, because that helps distinguish it. There's actually one case, I can't get into all these stories, but there was actually one case that I was a witness on that the patient had an MRI without contrast, misdiagnosed as a MET, and had delayed care, came back with paralysis. MRI, you want to MRI the entire spine because there could be skip lesions. You can have an abscess in the thoracic, skip a few vertebrae, and in the lumbar region. ESR-CRP, if you're trying to talk yourself out of it, because it's highly sensitive, so good negative predictive value, but not very good specificity. Now, if you're in a resource limited spot, like I work sometimes out in a rural area and you don't have MRI, it's not a bad idea to get a CT with contrast. You may be able to pick up discitis or osteomyelitis, which will be a clue. Management. Blood cultures from almost 60% are positive. Anti-staph and gram-negatives, you don't necessarily need to cover Pseudomonas unless there's specific risk factors. Please do not lumbar puncture these patients. You can make things worse and call a spine surgeon. This is the shortest part of my talk. We're going to go through central cord syndrome. So here we have a 64-year-old male with alcohol abuse, just complaining of left weakness, the weakness of the left hand times one day. He does not recall a fall, as a lot of these patients don't. And he has chronic neck pain. He says he has neck pain, but it's always there. He's not too worried about it. And then on further questioning, we realize that he has shooting pain on his hands. It's a little worse on the left, but in both hands. On exam, the patient's vitals are fine. He has maybe a little tenderness on the neck, but not really localized. And he has decreased grip strength on the left hand, mild, very subtle weakness on the right hand, and decreased sensation, possibly some decreased sensation left upper extremity. But normal rectal tone, normal perineal sensation, normal deep tendon reflexes. The C-spine is negative. The red flags of this case are the patient has alcohol abuse. He has chronic neck pain, which indicates that he probably has DJD or spondylolysis. And the fact that he has shooting pains to his hands is often a red flag for Colla syndrome. Obviously, the motor deficits on the upper extremity. There is no agreed-upon definition of central cord syndrome, but generally the definition includes weakness of the upper extremities greater than the left, and there's usually intact sacral sensation. There will be variable sensory deficits on the arms, and sometimes bladder dysfunction due to the cerebral control. The tract that controls the bladder from the cerebrum passes through the central cord. The typical patient is an older patient with a pre-existing spine condition that has a low energy extension injury. It is on the rise and is the most common incomplete spinal cord injury. It's on the rise because we have an aging population. The mechanism is compression of the central spinal cord between a bulging a buccal ligament flavum, and either an osteophyte anterior or a bulging disc, causing dynamic compression of the central cord and surrounding swelling in that area. So if you look at this, that's why you catch most of this medial aspect of the lateral cortical spinal tract, some of the dorsal horns, which explains why you have motor deficits. And you often can touch just the medial aspect of the lateral spinal thalamic tract, which explains the neurosensory symptoms. So with regard to history, make sure you, when you're thinking that there's new weakness, ask about trauma, because you could be thinking brain and it could be neck. Also, don't think just because it's asymmetric that it can't be central cord, and then ask about bladder dysfunction and prior cervical disease. Neuroexam, the only thing important is is that these patients usually have intact digital rectal tone and perineal sensation. The workup, you want to get a CT scan to rule out fracture, and you also want to get an MRI with contrast preferably, but you can get away without. In the meantime, you want to immobilize and consult the spine surgeon. One caveat is that you do not want the blood pressure to get too low. Anything below NAP, you maybe give first 1 liter fluids and maybe go to pressors. Steroids are not a thing anymore. So the big errors that people make on this failure to ask about trauma, they start working up CBA and look only brain instead of spinal cord because the patient doesn't remember a fall that they failed to ask and failure to immobilize. Take-home points is the last 3 slides, I'll be quick about it. Remember, you want to pick up the cauda equina, this is for cauda equina, you want to pick up cauda equina incomplete because you have the best benefit of that. Bilateral sciatica is a red flag for cauda equina. Unilateral, especially if new, does not exclude cauda equina syndrome, and recent spinal surgery is a major risk factor. Don't just perform a lazy digital rectal exam, have a digital rectal exam with squeeze and check how dull or sharp around the perianal region, and 90% of these patients will have retention. With regard to spinal epidural abscess, remember the risk factors I told you about. The classic triad is not reliable. ESR CRP is very sensitive. Almost 60% of these patients will have positive blood cultures and MRI the entire spine. And then if you can't, do at least CT with contrast, and 75% are missed at presentation. And with central cord, there's usually underlying cervical irregularity. Trauma may be minor or not remembered at all, especially in people with polysubstance abuse. And the symptoms may be unilateral at first, and you want both a CT and an MRI. Immobilize the C-spine until it's ruled out, and it is the most common cause of incomplete spinal cord injury, and it's on the rise. Thank you very much. Citations.